So good evening, friends. Particularly Dr. Rohan and Dr. Pratap CM. Uh, what we are going to talk today. Am I audible perfectly? Fine for both of you?
Yes, yes, sir, you are.
Okay. So what I'm going to show today is some of the technique. I mean the stepwise technique of using this Ahmedabad bolt. So let me start with the presentation first, and then I will see the bone model. So probably you will be able to see my screen. I hope you are able to see my screen.
Yes, sir, it is visible.
It is
Yes, yes.
visible. So we are very much thankful for the attendees and also for the Bonster who has prepared this Ahmedabad Bolt, and it's a good opportunity to share with you the technique and some of the results which we have seen on the patients. So basically, it is something which has got a male and female part, two components, and both of the components are cannulated. So once they are engaged with each other, the intra-articular fracture, particularly medial or lateral condyle of the proximal tibia, they can get a good compression, which is a watertight compression because of this particular technique. So this implant is basically having specialized instruments. So number one instrument is called Gujarat Guide. What do we mean by that is I'm going to explain to you what is Gujarat Guide. It is something like a 3 mm K wire which has got a slot at the end. And then we have three or four guide pins. Now these guide pins are not the similar one which we are using conventionally for so many other implants. This is basically both side, it is a blunt one. So it can be used only with the Gujarat guide because we cannot just use it and pierce it through our drill. So they are blunt. The third one is a cannulated drill, which is exactly matching with the guide pin. Fourth one is a tap, which is cannulated one. Then we have a depth gauge, which we are very conventionally using for so many other implants. But very important is a gauge stopper. Now, this gauge stopper is something by which we are going to get the precise length of the screw, Ahmedabad bolt. So we have in Ahmedabad bolt component 1, which is male part, and component 2, which is a female part. And then we have two screwdriver. One is a T-handle screwdriver. Both are cannulated, but as per the accommodation on one side or other side, because we need screwdriver on both side, medial as well as lateral. So one is a T and another one is a long one. However, you can use both side T, you can use both side long head also. So now with that, let me start. Like when you open up this particular instrument set, you'll be seeing on one side all the instruments, on other side the series of screws which are of a different size. These sizes are not the same one as we are conventionally seeing in other screws. These are going to be little odd with the difference of 5. So it is something which is like 53, 58, 63, 68, something like that. And I'll tell you how we have made this and how it matches with the exact size which we are going to use in the patient's body. Now, what is Gujarat Guide? Gujarat Guide, we know very well that conventionally we were using 2.3 mm guide pin, which was sharp, which we are using for 6.5 mm CC screws. Now, these guide pins sometimes they deviate inside. They do not go exactly where we want a precise position because of the physeal scar in the proximal or metaphyseal region of the tibia. For that, we use a 3 mm guide pin. Now, this 3 mm guide pin cannot pass through the cannulated screw. So, what we have done is that 3 mm guide pin is having a slot at the end, and through that slot, we are going to pass our original guide pin. So, what happens? You are making a trajectory, a track through this sharp Gujarat guide, and then when it is goes on the other side of the limb, like on the medial side to lateral side, thereafter we just insert this guide pin in the slot of this 3 mm Gujarat guide, and then we just do a rail rod, and through this rail rod we are able to position our original blunt tip guide wire. For the understanding, I have just made couple of the all these instruments into a black and white pictures. So the first one you can see is a Gujarat guide, where you can see on the rear side there is a slot. Then second we have this blunt guide pin both side which engages over here. Then we have this cannulated drill and depth, the depth gauge stopper, the cannulated tap, the T screwdriver and the long head screwdriver. So just think of that we have a bicondylar fracture. By all the methods and all the tricks you try to reduce that fracture, and then you can hold it by a K-wire or a clamp. So you know that it is a temporary holding which is well reduced. So what we start first is a Gujarat guide which goes like this. Say for example, if we start from the medial side, it will go out to the lateral side, or from the lateral side, go up the medial side. Once it has passed to the other side, then we put this blunt guide wire, blunt guide pin into that Gujarat guide, and then it is railroad. So ultimately, we are getting this guide pin into the position where we wanted to pass the Ahmedabad bolt. Now, this bolt is necessarily has to be little distal to the exit subchondral bone because there is going to be a head. So this bolt is having a very low profile head, both the component, male and female, and it flushes very well. So there is a little horizontal area just below the subchondral level where it fits very well. So after passing this guide pin, you are just making a drill hole with the cannulated, so the enough of the diameter is already made inside, and thereafter using on one side this gauge stopper and on the other side the depth gauge. When we put both together, and if you see very carefully, the depth gauge is having a, I mean, the depth gauge stopper is having a small hole by which we know that the guide pin will be over here. So we know this distance which is constant, and on the other side we'll be able to see how much is size of the screw. I'll just demonstrate it you on the table. So once it is done, we try to tap it so that all the subcontrol or whatever is the area which is very well easy to slide both the component. Then what we do is on one side, we measure this particular screw. On one side, we put one component, other side, we put another component. And then we know that when both the screwdrivers, when we start revolving, I mean, driving the screwdriver, we will be able to see that there is a good engagement of both the screws. And this we can appreciate very well under IITB. And this is a precise instrumentation and manufacturing where both these components will engage very easily inside the bone, inside the medulla of the proximal tibia. And this is what is very important. And thereafter, you just remove it and the job is done. One very important aspect of all this fracture fixation is that we had this sort of an impression that we can put a lateral plate, lateral locking plate. But usually when it is a bicondylar, when there is a medial condylar fracture, this is not sufficient because when the femur loads on the tibia, the medial side touches first. Because it touches the first, then even if you have passed a very good locking plate, it will be insufficient and there can be a sagging of the medial condyle. So what we do and what we recommend is that when there is a bicondylar fracture, you put a medial side a plate. Maybe proximal to that you put a Ahmedabad bolt to compress it. And then below that you can put a plate. I'll show you a couple of the examples. But once you do like this, when the femur comes down, it does not touch the lateral condyle, which is very important finding which has been found by Japan Orthopedic Association, that the up to first 60% of the weight there is a touching of the medial condyle of the femur with the medial condyle of the tibia. Lateral condyle is not in contact with lateral condyle of the femur. So what is required is there is no need to put two plates. You put couple of screws, or the screws from the medial side may catch all to the lateral condyle, and that is enough. So this is very, very important, that there is no need to go for two plates unless it is a very comminuted case, or unless it is a genu valga. In case of a genu valga, yes, the lateral side touches first. So there are very rare cases of like that. So now I'll just switch over to the table demonstration, and I'll just show you. We have a, I'll just stop sharing. We have a model which is a little soft one, and there with that model I'll be able to show you that how we go step by step. So I think you are able to see this model, and in this model, if you see, what we have done is, like, we think of there is a fracture medial or lateral condyle, and these are the different instrument set which you can see.
I'm sorry sir, I'm sorry sir.
Sorry.
સર તમારે મોબાઈલ નો સ્પીકર ઓન કરવું પડશે ને લેપટોપ નું બંધ કરવું પડશે.
Acha, okay, just a moment, huh? Okay, mobile speaker. Okay, first off, let me stop this. Speaker. Now, can you hear me?
Yes sir, we can.
Okay. So
Yes sir.
now, what we are going to show. Let me just stop this because I'm getting an echo. Right, not a problem. It's okay. So what I'm going to show is just. Can you see this instrument set? Right.
Yes sir.
So
Yes,
now
yes.
here the first one which I was talking about is this Gujarat guy. Okay, take this out. Now this Gujarat guide is a sharp one, but if you see carefully, there is a small slot. Okay, I think you can see. Now in that slot, hold this. In that slot, what happens is that this particular wire we put inside about, say, 5 or 4 or 5 mm. Now this is something by which you are able to pass the main guideway. Now let me explain the other part. Like this one is what is happening? Okay, you can see this. Now you are able to see. Okay. So these are the blunt guide pins, and this is a cannulated drill. This is tap, which is a very precise diameter, which has got a TPI which is equivalent to the TPI of the screw. Then this is the gauge stopper. And in that gauge stopper, you can see there is a small hole. Now that hole will give you an idea that when you are measuring, it goes exactly inside. So you can put it like this, and you know that that particular part has come. Can you appreciate this? Right? So this is very important.
Yes
Then,
sir.
then this is a T angle. These are the two screws, and this is a long T angle. Now just let me put it over the model. We have to just focus it. Okay, there is enough. Take it up. So what we do is, usually this is a soft bone, so I'll be able to pass with the hand only. So we first try to find out and get the reduction. In that, once the reduction is good, we try to hold it like this with a clamp. Zoom out. Okay. Like this, you can do it. and we can keep it, or we can pass couple of the K wires which can hold the reduction, which will not come in the way of final placement of the Ahmedabad board. So once we have passed this very slowly, and we have tried to take it out exactly where we wanted, I can just make it little down so that you will be able to see and appreciate. Okay. So this is how we have passed. Then what we are doing is we are going to put this guide pin as a rail rod, and then it has to be dragged like this. So it will go onto the opposite side, and then I just remove this uh, guide. So now it is placed
Sir,
there.
once can you show in lateral view as well?
Lateral, I'll just show you. That. Okay.
Through CM, we have to see in the lateral view as well, right? And then pass.
So what we can do is I just have to take it out.
Okay, that is
You
fine.
probably
We'll
will be
see
able to
later.
see. No, whether you are able to see now. No, probably you are
Okay,
able to
okay,
see,
okay.
right?
So under the CM guidance, we have to make sure we go in the
You have
lateral
to
view,
be
right?
very clear, precise about the. Just a moment, I'm
First, the
just
Gujarat pin.
focusing. Okay, very precise about the reduction as well as the placement of the final screw. Many a times, what happens that some of the frictions are such. This is going to be in a vertical view has come. Is okay.
Yes, sir.
Okay. Okay.
Yes, yes.
So some of the cases are such where we will not be able to find out the placement for the Ahmedabad bolt, because the limitation of the Ahmedabad bolt is it cannot pass through the plate. It has to be above or by the side of the plate. So that is the reason why you have to find out best way. I'll show you a couple of the cases that there are selected cases where you will be able to do it easily. Some of the complicated cases you might not get a placement for the Ahmedabad bolt. So after passing this, what we have done is we have just passed a calibrated hole, and then we have to go up to the opposite side. We have to be very careful for that. Thereafter, very important point is this measurement. So what we are doing over here is on one side, we are going to put this, okay, and on the other side, like. So on the other side, we have to put this. So there has to be enough incision on both the sides, which has been dissecting up to the surface of the bone. If this type of good dissection is not made, then the soft tissue will work as a valve, and you will not be able to go right up to the end of the bone. So this is very important that you try to see under C-arm that both these portions are touching, and then on one side you'll be able to find out the gauge. What I am saying in this particular case is we are going to use 63. Now, how we have decided this? Sorry, let us keep it like this. We have decided this is basically the component 2 is always a constant one, which you can see. Which you can see that it is 20 mm. So this is always a 20 mm, and the other will be a different sizes, whatever the different sizes you have. Now both these together The principle is that out of these 20, at least 4 to 5 threads should be engaged well. So after 4 threads, you get an 11 mm, 11 threads of compression. So you have a wide range. But now we are not going to compress up to 11 mm. There is no need. So we are going to compress somewhere around 4 or 5. So what is the ideal position at the end is that in IITV you should be able to see not completely touching both the component, but there is some gap, 2 or 3. Now this gap means that you have selected the right kind of a screw. If you have to put it like up to this, that means that it is a limit. There no more compression is possible. So probably you are using a longer screw. So you have to go with a shorter screw. So 4 mm, 5 mm is for the engagement and rest of the part is for the compression. So what we are going to do now over here is so one side, second side. What we do is simply maybe assistant is rolling on one side and this is like this. So inside we are able to see that inside, I mean through the IITV, that it is engaging. And then slowly if you go like this, all the surgeons have a very good feeling that they know, yes, I am now engaging. Because the precise cannulation, the size, and then the trajectory, all these things. Plus, as I told you, we have to be very careful that we have to fix the reduction valve so that we should not be losing the reduction. So now if you see, this is a good compression which I am getting it now, and both the low profile screws are touching and I am really feeling it. You can see that when I focus this, when I'm moving this also moves. That means they are engaged inside. You can appreciate this. So this is how ultimately it is an Ahmedabad bolt which can be kept like this. I'll just show you. I'll just remove this. And you can see in a lateral view as well as in a
Yes, sir.
keep it. Do not. This is the lateral side. This is on the medial side, and here you can see that how it has been fixed like. So now let me go to the some of the cases, and then we will have a question answer. So I just switch over to the. You can just switch off this camera. So now can you hear me?
Yes, sir.
Okay. So now what I'm doing is I'm going to share again the presentation where you'll be able to get a very good idea. I think you are able to see. Okay. Can you see my presentation?
We can,
Yes,
sir.
yes.
Okay. So now, so this is a case where, as I told you, there is a fracture and we have some good amount of medial condyle, which is longer one. So we had a liberty to put these screws, Ahmedabad bolt, and below that we had put this plate. So this was the fracture bicondylar, where it is not like only Ahmedabad bolt will work because then we have to have good connection at this level. So we have put a plate, but only 2 or 3 screws and 2 Ahmedabad bolt, and look at this, a final result. Very good healing, no loss of movement, I mean loss of reduction. And that is why this has proved to be so good that it does not allow any mal reduction, whatever reduction which has been achieved, it does not lose that. At the same time, it catches both the condyles so well that inside of the knee joint, there is hardly any leak of the synovial fluid. So in this case, what we have done is we have tried to find out that two level, uh, this anterior and posterior Ahmedabad bolt. So first we have tried to put it like whatever the way we can get the reduction which is can be maintained. And then after in the lateral view, you can see we have passed the second one. Then we have passed the first Ahmedabad bolt. The second one is also in the anterior part left out. Okay. Just a moment. So thereafter, we have tried to pass the second screw. So you can see this. Both the screws are very well fixed up. Here we know very well that the posterior border is very well reduced. So in those cases where this is not well reduced, you might have to open up a little, put some instrument and be very careful that posteriorly it has been well aligned. And thereafter we put the plate, which we know already conventionally. And this is how it can be done. So if you can see this, I am passing the posterior one, which goes like this, and we know that it has to come out on the lateral side. And thereafter we can pass the second one, which is anterior one, like this. And then we can put an incision for the both sides using this cannulated drill and then uh, tap and also measuring everything. We have to have enough of the incision. And this is how you can see and appreciate under IITV that both these components are engaging, and slowly you'll be able to know that yes, it is now compressing. So this is how it is going to work for the bicondylar. This is a very typical case and minimally displaced, but because it is bicondylar, we need an early mobilization, and for that we need to fix it. Slowly as you go, then you know that a couple of these threads should left out. It should not like both the components are meeting each other fully. Then only you are going to get a good compression. And this low profile head works so well that there is no need for washer unless there is a coronal slit where we feel like. But then those cases we prefer other methods rather than Ahmedabad bolt. This is also very interesting. So this is how once it is fixed on the day two only you can start mobilization, because this is something which is very dependable fixation. We can also use such bolt for the lower end of femur. Now this is the case where there was a very small slit and there was a Hoffa's element which was little anterior. So I just put couple of screws and then this bolt, and he was able to do a good movement. So it is also possible even if there is a fracture. This is a case where there is a fracture above, where there was some problem and there was screw breaking, but then he sustained another fracture which was like this. Now, these are the cases which are very, very much suitable for Ahmedabad bolt. And this is the plate which we call it as a point supporting plate. There is another lecture on it. But this is a plate which is a very thin one like this. Only you just passed a couple of screws. You do not want to allow weight bearing through the plate. Weight bearing will be through the bone. In all those cases, we have just passed two screws and you'll see the final result where you won't be able to find out where was the fracture and absolute healing. It's a very good case. The similar point supporting plate which has been used for this case where there was a very small fracture on the medial side which we could appreciate in a CT scan. So we wanted to support that. So we put a small plate and these two Ahmedabad bolt and is able to do the movement early. These are the cases where we know that medial side is completely intact. The medial wall is intact. It's only a problem with the lateral condyle where you can pass even two screws of the different sizes. And once you do that, it goes with a very good healing and you can have a complete movement, a very satisfying both for the patients as well as for the surgeon. Okay. Now, there is another case where we have put, a similar case, we have put these two Ahmedabad bolt and you can appreciate under IRTV the stability of the fixation. So this is also a very interesting to see after passing two bolt how the stability occurs. This is a very bad fracture, a huge depression. The lateral condyle has gone down up to 3 centimeter, which has been slowly elevated up. And then it two screws, one is CC, one is Ahmedabad bolt, and another one is anteroposterior, which is like a girdle screw, and only one screw at the lower level. And you can see a very good result, a complete good healing. And as I told you, on the lateral side, you have not to worry too much because lateral side is not initial weight bearing. It is only for the contour and for the good stability of within lateral condyle of the femur. We have to reshape it. Otherwise, it's not going to be indirectly in touch. So this is the case we can see a 3 centimeter of depression of the lateral condyle. Most part is just posterior part to the middle in the lateral view. So what we have done is because there was a medial condyle small slit in a coronal, we first ensure that the medial condyle should not be disturbed. So we put a clamp on a medial condyle reduction, and then with that clamp we know that posteromedial condyle and the medial whole slit is okay. Then we pass anteroposterior guide pin which goes absolutely, it is not a guide pin, it's a K wire which goes subchondral, and we hold that particular fracture. Then we pass a guide pin which is below that on medial side. So now we know very well that medial side is not going to displace. It is undisplaced. We want to keep it undisplaced. Then we make a fenestration on the lateral side, and this is the fragment which we want to take it up. So what happens in a lateral view, anterior, and also in the AP view, we try to find out and put a awl to make a good fenestration. And then with this doubly curved punch, we start pushing it up. So you can see that it has been elevated slowly, frame by frame. And then we try to see in the anterior view, anteroposterior view as well as on the lateral view. In the lateral view, we have to be very careful that it has to be cross stable. You cannot just go on rotating the limb. So you have to paint and drap the limb in such a way that it is little elevated with a long pillow so that you can see lateral view with a cross stable IITV position. So here it has been pushed. We have to all the time find out the right place, and then at the end you will be able to see that it has been rotated well and put it back to that position. So fairly good sort of reduction is achieved with different types of tools which we have passed through the fenestration. And then at the end, we know that once we are satisfied with that, we can pass a guide pin just to hold that elevation well. It may be passing through the fragment, and we keep bicondylar clamp so that the width of the both sides condyle is very well maintained. And thereafter, you can see that the perfect trajectory is there. So I have passed two K wires. So the below wire is a based one where we can do Ahmedabad Bolt by this cannulated drill, and here is the male component and the female component, which you can see, and slowly we are trying to fix it up. And this is how the bicondylar compression has been achieved. We had passed one K-wire proximal to that, where there is a little less space available, so we put a 6.5 mm CC screw. And after that, when we know that there is a below crack, so we put another cortical 4.5 mm screw. But very important is passing of this anteroposterior screw, which is like a girdle, which is also going to catch hold of the prostromedial fragment. All these things can be done without use of plate. Now, this is something very interesting for all of us, that such a minimal invasive can be done. There is another case where there was an interlocking nail already with a lateral, medial condyle of the femur which was fractured. So we just put a Ahmedabad bolt with whatever the space we got. There was also a fracture of the patella, for which tension band wiring was done. Cases like this, a single Ahmedabad bolt is sufficient, and you will get immediate uh, movement of the patient. Of course, weight bearing we cannot start early, but without any brace or any slab, we can start mobilization, and it will give you. Now, this is what is another film which we can see that how railroad is done. But after the Gujarat guide, we are passing this guide pin. So we have to be very careful that the one who is dragging the drill is not dragging so fast, so that it remains engaged. This is another case, lateral side, a single screw. And look at this, such a heavy patient is having a complete good reduction and good healing with a good functional movement. So this is very much satisfying. With one bolt you are able to get all we wanted. Of course, this is a case where the medial side is intact. Another case, little bit of depression which has been elevated, one single screw, and she has got a complete recovery. This is the final X-ray, complete recovery with a good functional movement. So such cases where we also have tried to find out post-operatively that how much is the actual placement through CT scan. So we have got this particular movie. This is a post-operative where we try to find out where exactly is the screw, how it is engaged, just to study it more. So this is the case where there was a fracture on the medial side. We have put this, but then we have also have put one anteroposterior screw to catch hold of the medial side valve. So there is an Ahmedabad bolt with one screw, and that is sufficient. And that is how it gives very good results. Similar case, two screws, full movement, good union. This is a case where we have to put this Ahmedabad bolt little proximal, and then below we have to put this particular plate. Sometimes it is very difficult if the fracture is very much near like this, then we avoid Ahmedabad bolt. But here we wanted that this particular anterior angulation should be taken care of. So we had to put a plate by which we can just take care of this anterior opening. And unless we pass minimum 4 screw distally, we are not able to fix this valve. So all the combinations are required. This is a combination where there was a very bad anterior fragment which was all the time getting elevated because of the pull of patellar tendon. So we add one more buttress plate anteriorly. So Ahmedabad bolt, medial plate, and one buttress plate to take care of this. Very simple case, but we know that there is some sort of a rotation on the medial condyle. So what we do is we pass the K wire, we do indirect intrafocal reduction, and we try to rotate it and get the best of the reduction. Once we get that reduction, we know that it may be little away, but it is a good reduction. So ultimately, when we pass the screw, it is going to fix it well. So we have made all the trajectory for the Ahmedabad bolt, and thereafter we pass below another bolt. Now you can appreciate with these two bolt, there is a reduction which is called point supporting reduction. With the point supporting reduction, the weight will go through the medial cortex from the proximal fragment to distal fragment directly. Earlier, there was conventionally, there is a principle that you pass a plate. So the weight bearing will be through the screw to the plate, then to the plate to the screw, likewise. But here, the weight bearing passes through the contact of the medial cortex, proximal and distal fragment. So here you can appreciate this is how it has been passed the proximal side. And then once we know that the Gujarat guide has been put very well, the below wire is basically for fixing the lower part, which I told you in a derotated manner and then in a very good reduction. And thereafter, we engage this drill on this side, and with this engagement, the assistant is holding the real blunt tip guide pin into that Gujarat guide, and we are able to pass like this. And thereafter, you just hold it on one side, you try to drill it through this, and drilling has to be completely up to the opposite side. Sometimes if you go little less, then the soft tissue might not be able to take you out, so you have to be very careful. Then with this you try to get the proper size, and once you put this gauge stopper, it will touch there, so you have to push it back, and then you have to find out the best size, and then you go with the taping. On the taping also, on one side you hold the guide pin so that you do not lose the track, and then on both sides, once you fix it, you are going to get the best of the compression, which you can appreciate well. And this is how you can see under IITV that it is engaging well. Very rarely you might have to be a little more careful, but even in osteoporotic bone, I have found out that this cannulated system engages the both the components so easily. So this is how you can see that ultimately it has been fixed well, both sides, and patient is able to do mobilization on day 2, where there is no need to go for a big plate, and all the structures are saved. And this is probably another case, which is the last case, where there is a vertical fracture of the lateral condyle, which we have put a 2 Ahmedabad Bolt. And here you can compare that this was a pre-operative CT scan and this is a post-operative CT scan, how these screws are engaged and how it is very well accommodated inside the metaphyseal region of the tibia, and you get the final movement like this. Look at this, a fantastic reduction, holding of the or maintenance of the reduction, and full union and squat and smile sign where patient is able to do without any pain. So all these cases can be very well fixed with. So just to remind you again, get the reduction, fix the reduction or hold the reduction by a clamp, pass Gujarat guide, over that do a railroad with a blunt guide pin, then you try to drill it with a cannulated drill up to the opposite side, and thereafter you try to measure the size of the screw with a stop gauge, gauge stopper and the depth gauge. In the combination of that, select the particular size of the screw. Then on one side, after tapping, you can put it on one side male component, on other side female component, and then try to be very cautious under IITV couple of exposure that it is engaging well, and you'll be able to have a great feel of that. So friend, this is what I just wanted to share with you. I hope I could convey you the clear idea of the innovations which we have made, which is called Ahmedabad Bolt. Thank you. Yes, if Dr. Pratap, if have any questions, Dr. Rohan, just let me know.
Hello.
Yes, yes.
So I just want to know, have you encountered any complications in this?
No, no complication because the selection of the patient is very important. See, what happens is
Okay,
that I
and
had one time one of my resident who he used a smaller screw. So he engaged fully. He tightened so much and he was not getting compression because he forgot that the proper size of the length is not there. In those cases, what happens is that because it is a cannulated one, both side screwdriver, it is easily it can be removed and you go with the proper size. Very rarely it happens that if you have not gone through the CT scan, you might miss the coronal plane vertical line, and through that you are going to pass the screw. In all those cases, we have to be very careful. Otherwise, technically, no complications.
one more thing, while inserting that Gujarat pin, what if we make multiple holes?
Oh,
Like, see,
no,
complication can occur
huh,
from assuming from medial to lateral we are going. In the lateral, if
yes,
we don't get the correct spot, we'll
yes,
come back and make another hole.
yes. So what happens?
So how to
What happens?
overcome that?
Yes, what happens that say the entry point is one, but the exit point may be multiple because you are not very much satisfied with that particular trajectory. So once there are multiple on the other side, not to worry, because when you pass the blunt guide pin, and then when you drill it with the cannulated drill, and then when you tap it, it makes an enough of the root, enough of the canal, then it is not going to deviate. And a very important part is you do not start cannulated drill unless there is a good final position. So the surrounding bone will be still intact. And we have not faced that
Yes.
problem anytime, even if we go with multiple. So, but you have to be careful. Multiple is basically when I tell you, when on the, say for example, you are starting from the lateral side, you are passing, but on medial side, you might come out too much posteromedial or too much anteromedial. That is what is commonly occurring rather than distal or proximal. So you have to be very careful and you have to, that is the reason why I told you that the patient should be supine with a long pillow so that you can get an exit, that sort of a sense and a view that you are how much
Positioning the
horizontal,
90
how much you are.
flex
Yeah.
position.
Yes, yes. That,
Okay, okay.
right, right,
Thank you.
right. Jai, Dr. Rohan, do you have any question?
Yes, sir.
Uh, uh, I don't know if Dr. Rohan has got any questions.
That's it, sir. That's it.
Uh,
That's it. Thank you.
okay, okay. Thank you, thank you, thank you.
I just had, regarding the complication, because we
Yes,
need to
yes,
be prepared for that as well. So it's
yes,
better to know
yes.
before anything.
So two, three times what has happened is that when I wanted to pass the screw, I was too much proximal. And I thought that my head of the Ahmedabad bolt might catch on the capsule. In those cases, we pass CC screw. So we have to be very careful because ultimately you have to find out where is going to be the final placement. And very some of the cases where there is when you take a CT scan of the transverse section and you see that the fracture line is very oblique. In those cases, we have to pass the Ahmedabad bolt, say for example, anterolateral to posteromedial because it has to be as right angle as possible to the fracture line. So all those things are very much required for as a homework and you be prepared and then you find out the best trajectory where it can have a best of the compression. Right then. So, Jai, thank you very much. I think
Thank you, sir. Thank you.
we have a good
Thank
amount
you,
of
sir.
discussion. Thank you. Thank you.